is at the level of MBBS. And it is good to refresh those things because time has changed. Actually, the healthy pregnancy and outcome of a healthy pregnancy is very much required in current era. And healthy outcome of the pregnancy is very much required in current era. And those were the days where ultrasounds were not there. So simple clinical examination, based on the clinical examination, fetal well-being was decided. But in current era, there are so many tests which helps in well-being of the embryo, well-being of the fetus, and then well-being of a just of a baby who is just to be delivered. So let's start with the initial thing that you can look at this, that 20 to 40% stillbirths in the non-allomous category occur as a result of intrauterine hypoxia. And this is a major after prematurity, birth asphyxia, or the fetal hypoxia is one of the major contributor for so many morbidities. Where once the hypoxia occurs because of any reason, the growth of the fetus is jeopardized. And once the growth of fetus is jeopardized, when to deliver, how to deliver, that comes into question. So my presentation will be related to all those things. But before that, how to pick up the problems in the first trimester. So the question is, do we need to ask for fetal surveillance in all pregnancies? Let's say a primary mother, a healthy pregnancy, uncomplicated maternal period, antenatal period. Do we need fetal surveillance for that? Those healthy pregnancies may not be. But the once the trigger is raised about something going wrong with the baby or something was wrong with the previous pregnancy, then with the current pregnancy, the fetal surveillance is required. So if you look at typical maternal indications, fetal death, some maternal illnesses, multiple pregnancies, recurrent pregnancy losses, mother drugs, maternal drugs, these are the absolute indication to see that all these maternal problems are not affecting fetus, and for that matter, monitoring of the growing fetus is required. Once we pick up that baby is not growing, that is your IUGR or SFD or fetal growth restriction, we'll deal with that little later. Once that has been picked up, then further monitoring is required to see that whether they are growing or not. If not, what else can be offered to the baby? Baby with some abnormal finding on the ultrasounds, RH isomnations, malformations. These are the one we look at other associated malformation which can give us some clue to the well-being of the baby. So the moment the embryo is formed, that is somewhere about at 4 weeks around, at 6 to 8 weeks, the first scan is known as a just to confirm the pregnancy, and that is known as a dating scan. Good number of time, mother doesn't know LMP, or she is not sure about the LMP. So in that case, the femur length at 6 to 8 weeks will tell us exactly when the conception occurred, and based on that, expected date of delivery is decided. So the first 6 to 8 week scan will tell presence of the baby's of fetal pole, cardiac activity, single or double or multiple, whatever is that, placenta is appropriately placented or not, or roped or not, and date of the LMP and EDD. This can be confirmed with the first scan, which happens at 6 to 8 weeks. Then comes to rule out any anomalies which are obvious or which can happen because of the chromosomal problem. So then you are looking at some markers. Markers are in form of some chemical test or the laboratory test, and in form of some ultrasound reports. So a first time, a target of the first time screening would be picking up the early anomalies, aneuploidy screen, uterine Dopplers, and length of the cervix. Uterine Dopplers to see that perfusion of the placenta is going to be adequate or not. If the placenta is not perfused, it is associated with some improper abnormal outcome of the fetus and also complication during the pregnancy. IUGR and PIH, these are associated with abnormal uterine flows. So the first initial period of the pregnancy, you are looking at overall well-being of the uterus, placenta, and the fetus, because still malformation may not be picked up at this stage. So you are looking at some other laboratory test based on which you can pick up whether trisomies or aneuploidy can happen to this fetus or not. Second trimester, 18 to 20 weeks, you are looking at targeted imaging for fetal anomaly, TIFA scan, and then you look at the fetal echo. So from 10 to 24 weeks, you are looking at three major examination points. Number one, looking at the anomalies, aneuploid screen, uterine Dopplers, and cervical length, that is 11 to 14 weeks. There are some tests which we'll discuss in the next slide about the whether which we can say double marker or quadruple marker. After 18 weeks is a major anomaly scan, date scan they call it. They look at the major anomalies at then. At 18 weeks, still the chambers or the circulation is not fully established. So in that case, proper cardiac anomaly scan is happening at 24 weeks. So these are the scan dates that one need to remember. Late span is when baby is growing now, maybe you are in 3rd weeks. That's the time you are preparing for the baby's delivery or preparing for the baby's growth, like movements. So daily fetal movement count is the one by which you know that fetal is going well or not. Ultrasound at 20 to 30 weeks is to pick up the Doppler flows and placental perfusions, and with the growthing with the babies getting into IUGR or fetal growth restriction is happening or not. And then based on biophysical profile, you can also judge whether baby is doing well in uterus or not. So first let's talk about aneuploidy scan. Double marker, which is PEP-A and protein associated with amniotic fluid, and the free beta HCG. These are the one which are produced by the placenta, and associated, if they are low, then they are associated with, as such, beta HCG is going to be high because it is secreted by the placenta. But PEP-A is a protein associated with the amniotic fluid. That is the one which is, if it is low, then it can be associated with trisomy 21. Quadruple marker, which is in the 2nd trimester. This is alpha fetoprotein, beta HCG, unconjugated estradiol, and inhibin. These are 4 which combine, which can be combined together, and that it will suggest whether trisomy, it will suggestive of trisomy or probability of trisomy 21. Alpha protein, as I said, that is been produced by the placenta, and this is the one which goes, if it is low, then one need to think about it. Beta HCG abnormally high or higher than the average, estradiol levels and inhibin levels. These are mainly produced by the placenta. Inhibin is the one which is produced by the ovarian placenta, and these are the one which combined together can give us some probability whether baby has got trisomy 21 or not. If you combine together, look at this. First trimester, you are looking at knuckle translucency, and we all know this is to be done by ultrasound. There is a lack of some fluid around the neck, at the back of the neck. If the translucency is being measured in the millimeter, and if it is more than certain numbers which are specific for the gestational age, then it is abnormal. Combined with PEP-A and beta, got the double marker, it gives the probability of trisomy 21 by 80 to 87%, and false positive rate is just 5%. 2nd trimester quadruple marker, we discuss alpha fetoprotein, beta HCG, estradiol, and inhibin. These are associated with 81% detection rate of trisomy 1, and false positive is 5. Combined together, 1st and 2nd trimester quadruple markers, where because the PEP-A is done during the 1st trimester, remaining 3 are done in 2nd trimester. This combined together will pick up the trisomy 21 by 95%, and 5% is false positive rate. Serum integrated quadruple scan and PEP-A again what I want to convey here is that combining various tests which increases the possibility of detection of trisomy 21. If it has been detected, then remaining thing can be planned. But there is something new in the market which is known as a which is known as NIPT test, non-invasive non-invasive prenatal testing. What you are going to do is you are looking at the fetal DNA in mother's blood. The mother blood is taken. This DNA is from the placental side, which is coming to the mother. It is from the placenta, chorionic villus. These samples are coming. This blood is coming. This DNA is coming into the mother's blood. It is to be separated. And if with this, the detection of trisomy 21 is 99% and the false positive rate is less than 1%. That means we have something by which you can be assured that mother is not carrying a baby with trisomy 21. With age, the sensitivity remains same, which is most important part of this test. With increasing maternal age, 20 years to 40 years, the sensitivity of this test has remained same 99.7%, false positive is 0.4%, negative is more than 99%. So if this is negative, that means chances of trisomy 21 are negligible or less than 1%. And that is what the current era, that is what is being offered in the current era for the mother to be stress free, to making sure that baby is otherwise fine and no chromosome anomalies are being picked up are there. What is NIPT? It stands for non-invasive prenatal testing. It is a method of determining the risk that fetal will be born with certain genetic anomalies. It is not about trisomy 21 only. There are so many other chromosomal anomalies which can be picked up with NIPT. It is based on the analysis of cell-free fetal DNA, which is circulating in the mother's blood due to passage of DNA fragment into the metacirculation through the fetal-placental vessels after apoptosis of fetal cells in the placental bed. So this is coming from the placenta, fetal cells getting into the maternal blood. You separate that. In fact, if you look in detail, this this cell-free fetal DNAs, they are very much into use for diagnosis malignancies. These are not the fetal cells, but the tumor cell known as a cell-free tumor DNAs. And these are there in the patient. People have developed appropriate PCR to detect this DNAs. Cell tumor DNA, ctDNA. This is cfDNA. This is known as ctDNA. And with help of the different PCR, you can pick up these tumor cells and you can treat malignancy in time. So early test to pick up NI and chromosome anomaly from the fetal cell in the fetal cell, which can be picked up by testing maternal blood. So the question is, when NIPT is to be done in the pregnancy? First of all, enough amount of cfDNA has to be there so that it can be picked up. Before 10 weeks of the pregnancy, the CF or cell-free DNA is not there in the mother. It is not enough, which can be picked up. So either test would be 10 weeks onwards, anytime this can be done. And it has to be more than 4% to be picked up. So before 10 weeks, it is less than 4%. After 10 weeks, till the full-term pregnancy, it is more than 4%, which can be picked up very easily. What is specificity and sensitivity? We already discussed this part, that sensitivity is almost 99%. False positive is, sensitivity is 99.7%. And false negative predictive value is more than 99%. So that is where the importance of this test lies, that worth offering to the patient, particularly detection rate for the trisomy 20 is very good. Not only 21, 18 and 13 detection rate is about 96.3% and 91%. not bad, because at times before, as we know that this can be offered after 10 weeks. So moment you find any problem with the first or second trimester scan, the next investigation in the list would be NIPT. And once NIPT is abnormal or normal, then further investigation will be decided. So once the false negative, the occurrence of false negative is believed to be due to low amount of cell-free DNA in the maternal plasma influenced by the advanced maternal age, high BMI, and early gestation. So chances of false negative cell-free DNA or false negative NIPT is because of advanced maternal age, high BMI, so obesity or heavy mother, and early gestation, where you get false negative. False positive is because of the confined placental mosaicism, vanishing twins, and maternal tumor. As I told you that it is associated with the malignancies. So maternal tumor itself can cause false positive, where fetus is fine, but because of the maternal tumor, this test is coming positive. What is the risk involved? Nil. Why so? Because you are going to take only maternal blood. You are not handling anything in the uterus or in the fetus. So very safe test. Next question is, if NIPT is abnormal, what is next? That means if it is abnormal, means you are looking at some chromosomal problem, maybe trisomy 18, 20, 21, 13, or something else is there in NIPT. You can pick up the number of the chromosome with NIPT. You can't pick up anything beyond that. So if it is coming positive, what is next? That means we need to look at the fetal blood or amniotic fluid to decide what is the whether it's a true test or not, because more of it is a screening kind of thing. But if it comes positive, then we not look at the fetal blood, and for that matter, we need to take amniotic fluid through the transabdominal puncture. Ideally, this is to be done after 15 weeks. Ideal time is, as I said, 16 to 20 weeks. Having said that, this is you are touching uterus. You are going to puncture this transabdominal puncture. So there is some minimal risk of having abortion after the procedure. So procedure related risk would be about 0.1 to 1%, and risk is of miscarriage depending on the operator's experience. If you want to be doubly sure, then photosynthesis or coronary villus sampling. Here you are going to handle fetal blood or a fetal tissue directly. So that will increase the sensitivity of the test. It will exactly tell about the chromosomes or the DNA of the fetus. And based on the current era, based on the anomaly, you can decide whether you want to go for next generation sequencing NGS or microarray from that blood or from this coronary villus sampling. Because microarray and NGS, that will give a real picture of what is wrong with the fetal DNA. So many syndromes, so many anomalies, so many things can be picked up with NGS and microarray. Having said that, microarray and NGS again will not give 100% certainty that fetus is normal. Still, there are chances that some syndrome which are not genetic related can be there in the fetus. So we know that most sophisticated tests are available in current era for the mother and for the fetus, but all tests will not give 100% certainty of normal fetal outcome. So what is coronary villus sampling? This is from the coronary villi in the developing. You just put a. We all know about the procedure, but you look at the coronary villus placenta tissue or the coronary villus tissue. When it is to be done, ideally would be 11 to 14 weeks. So generally, you can see that you are looking at the all these tests between 10 to 20 weeks. That is end of the first trimester, beginning of second trimester, where you want to make sure that fetus chromosomal anomalies are not there. Anomaly scan is been done, cardiac scan is done, double marker, the quadruple marker is been done. All these things can tell us whether aneuploidy or some chromosomal malformations are happening or not. Either venous coronary villus CVS or photosynthesis. Either of that is going to tell us about the fetal, about the anomaly, chromosome anomaly in the fetus. Here, when you do chordosynthesis, I must say that good sonologist is required. Fetal medicine experts are available in private or the government practice. They are the one who can handle the fetal this kind of procedure very well. If done properly, then mostly doesn't carry any risk. Of course, there is some minor risk of about 1 to 2% of the miscarriage in all these pregnancies. When should monitoring begin? When obstetrician is prepared to deliver the fetus, usually around 32 weeks or 1 to 2 weeks before stillbirth in the prior pregnancy, and decisions should be individualized. This is about now mother or pregnant mother is getting into third trimester. This is a time where you're looking where the placenta is, whether baby is growing properly or not, whatever the amniotic fluid, fetal tone, fetal breathing, fetal movement, and most important part would be Doppler assessment. Doppler for the fetal well-being. Let's see what we can offer. So first in the list is non-stress test. What is this? This is based on the principle that a well-oxygenated fetus responds to spontaneous or induced movement with fetal heart acceleration. This will rule out fetal hypoxia. Because if there is fetal hypoxia is there, obviously baby is not moving actively is not moving actively, and so that the cardiac acceleration is not there. Normally you find heart rate going up with fetal activity, but when baby is compromised, there is no acceleration of the fetal heart rate with the fetal movement, and that will suggest that something is wrong with the baby. Acidosis and fetal hypoxia are main culprit, may be related to the Doppler flows, may be related to placental dysfunction, may be related to anything. But without major intervention, this is more of a non-invasive test to pick up the fetal Jeopardis fetus or fetus in trouble. Important is this, that you need 20-minute record. So you need to enough time for the mother to be with the obstetrician, lying on the bed quietly, and this test has been done. What is reactive test? We are looking at reactive test. Reactive test means that baseline fetal rate is 100 to 160 per minute with at least 2 acceleration of 15 or more beats lasting for 15 seconds. So fetal heart rate is 110 to 160 per minute, 2 acceleration of 15 or more beats lasting at least for 15 seconds. If you get this, it is a reactive test. Here you can see that baseline heart rate is somewhere about 150. It is going to 170. And this is lasting for more than 15 seconds. And that is a reactive test. You can see no acceleration happening here. And this is the one where the baby is in trouble. There is no cardiac acceleration with fetal movement. And this suggests that baby is either hypoxic or baby is acidotic. If criteria is not met for 20 minutes, you go for another 20 minutes. That is total 40 minutes. And if this is not, if your NST is not reactive, then next would be looking at the ultrasounds and looking other things to mainly looking at the biophysical profile. At 20 weeks, approximately 65% of fetuses have reactive NST. At 28 weeks, 65% fetuses have reactive NST. So before that, there is no role of this test. Earliest would be 28 weeks. As baby grows or as the fetus is growing, the chances of NST becoming reactive increases. So at 32 weeks, it is 85%. At 34 weeks, it is 94% fetus will react. So someone performing NST at 28 weeks, it is not reactive. Maybe that fetus in that 35% where it is told not reactive. Only 65% of the pregnancies at the 28 weeks, the fetus will be having reactive NST. And when you get non-reactive NST, next would be you are looking at something else. You are looking at some more test for the fetal well-being. So fixed baseline fetal heart rate with poor baseline variability, loss of acceleration, and spontaneous fetal heart decelerations are found to be consistent with fetal hypoxia and acidosis. We are all concerned about that. Baby outcome, this is because it is associated with the long-term fetal outcome. Morbidities, which are baby will come out and cry lustily, but because of the intrauterine hypoxias and the acidosis which has gone unnoticed, the long-term outcome may be affected. It is associated with many morbidities. So when your NST is non-reactive, you are looking at biophysical profile. What is that? It is a prenatal ultrasound evaluation of fetal well-being. It involves scoring system known as a Manning score. And what is this? You are looking at breathing, movements, fetal breathing, fetal heart rate, muscle tone, amniotic fluid, and NST. When you talk about only biophysical profile, you are looking at only 5 things: heart rate, tone, breathing, movement, and amniotic fluid. Amniotic fluid, you require USG. For rest of the 4 thing, for the rest of 4 thing also you need USG, but out of these 5, amniotic fluid can be done quickly. Rest 4 thing, you need to sit with the mother and you need to wait for the baby to breathe. You are looking at the flexure movements. You are looking at the muscle tone activity and looking at heart rate. Heart rate can be picked up easily. Amniotic fluid can be picked up easily, but at times, movements, tone, and breathing will take some time. Anyhow, this is the table which tells us about how to score biophysical profile. In all, anything between 8 and 10, it is to be scored out of 10. Anything between 8 and 10, there is no fetal asphyxia, continue the pregnancy, or it is a healthy baby, healthy fetus, growing well, repeat weekly, or maybe twice, maybe every second week or third week. Anything less than 8, particularly 6, it suspects chronic hypoxia. And that too, if you find that you are able to manage that fetus by delivering early, you should deliver early, maybe 34, maybe 36. But biophysical profile of 6 or less is associated with some compromised fetus, fetus hypoxia, and acidosis. If you look at the probability of mortality, anything abnormal score of 0 to 4 or 6 with oligo score of 0 to 4 or 6 and there is oligohydramnios, the probability of parental mortality is 12 to 300 per 1000 pregnancies. If score is equivalent at 6 or 8 with oligohydramnios, probability of parental mortality is 7 to 10 per 1000. And normal score, where is less chances of poor outcome. So biophysical profile, you are talking about scoring from out of 10. 8 to 10 is normal. 6 is magic figure, less than 6 or 6 is abnormal. Less than 4, by any means, baby is to come out. Excel suggests what is next is modified. Okay, this is what we know, that acceleration suggests good aerosol reserve. Fetal breathing movement indicates well functioning midbrain and cerebral cortex. Normal amniotic fluid indicates well perfused kidneys. That is fine. What is modified biophysical profile? Why modified profile? Because as I said, that BPP required, normal biophysical profile require a little bit more time. And after addition of fetal medicine specialists need to sit with the mother, keep on doing the scan, look at the breathing movement, look at muscle tone, look at other things. What you can quickly do, a quick ultrasound can associate that with your amniotic fluid index. So short term, you do NST, and out of your biophysical profile just to amniotic fluid. This can happen quickly, and that will give you another another assurance that how the fetus is growing. A reliable predictor of long-term fetal well-being as a full BPP, same rate of stillbirth within 1 week of modified BPP, or normal BPV. So outcome as far as the predictor of poor outcome is concerned, as far as stillbirth is concerned, both are same. So non-reactive NST or AFI less than 50 millimeter requires further fetal assessment or intervention. So now what about further fetal assessment? That is, you are looking at Dopplers. Let's talk about what is AFI. Amniotic fluid being produced in the kidneys, membranes, lung and skin that we know. And it has been absorbed in the it has been passed on the GIT, lung and membrane and cord. So the GIT and the lung and membrane are the one which produces it. It has been taken out by the kidneys and lung and the skin. So this is what is happening. A balance is required to make sure that appropriate amniotic fluid is there in the uterus. Sorry. Basically, you are looking at you divide uterus into 4 quadrants, and you measure AFI in these 4 quadrants. You measure largest pocket in each quadrant, and then sum of all 4 is your amniotic fluid index. So this is how we are going to do that. Uterus is divided into 4 quadrants. The largest pocket in each quadrant is summed up, and that is what the AFI is. So there is no like a there is oligoambrous when the score is less than 5, and where is score is more than 25, that is polyhydramnios. So less than 5 or more than 25 is suggestive of some problem with the amniotic fluid in the form oligo or the poly. As I said that 5 to 8 is borderline AFI, 8 to 25 is normal, and less than 5 or more than 25 is abnormal. When there is oligoambronios, this is possibility of because of the oligo, when the uterus contracts is or baby's movement, the cord compresses, and that cord compression can cause fetal hypoxia, can lead to mechanism staining. So chances of cord compression related fetal hypoxia is very high with oligoambronios. Not only that, when it's a chronic in nature, let's say the less liquor or no liquor for maybe 5 to 6 weeks, the limbs are not moving at all, and baby will be delivered with some limb contractures. At the same time, there is no liquor, lung also will not develop properly. It is associated with hypoplasia of the lung also. And chances of stillbirths is very high in cases of oligoambronios. So what is next? Less than 5 or 8 centimeter, very close monitoring of the AFI is required. Once it goes below 5, most operation will like to deliver the baby, provided we as neurologists are ready to take care of the babies. It depends on your NICU ability to save at that particular age of the gestation age. Next question is, obstetrician is calling you that should I deliver this baby or not? As I said, it all depends on you. If you are able to manage those babies at early gestational age, babies to be delivered, but not only based on oligoambronios. It is not the one indicator with which you decide whether baby is to come out or not. There are many other parameters based on which you decide whether baby is to be delivered or baby is jeopardized or baby is in trouble or not. Which are those? As I told you earlier, it is a colored Doppler of umbilical artery, or color doctor of ductus venosus, or color doctor of middle cerebral artery. These are 3 important vessels which obstetrician will be where you are looking at the Doppler, where we are looking at the waves, whether they are there or not, and based on that, one will decide how much severity, what is the severity of placental circulation or placental insufficiency or fetal circulation problem. Polyhydramnios, fetal causes, cerebral dysfunctions, obstructions, we know fistulas, we know the intestinal problems, cardiac overload, chromosome anomalies associated with the polyhydramnios. Teen to teen transmission syndromes, chorioangioma, maternal diabetes, and RH isomers, these all are associated with polyhydramnios. Which are the consequences? Most common consequences of polyhydrosis is early delivery, premature rupture of membrane, and that was spontaneous. Problem is that with too much of the LICA there, membrane ruptures and cord can come out, and these are the one which end up with cord prolapse and asphyxia, because this is the one which can happen at home or the middle of the at any stage this can
भीड़
happen.
में और भीड़ मत बनाओ, वो तो ऐसे बोलते हैं भीड़ बढ़ाओगे
Hello.
साल में 2 टाइम हो जाता है।
Hello.
Sarita ma'am, can you mute the participants?
Sure, ma'am.
Hello.
Hello.
Yeah, ma'am, I will.
And this polyhydrosis also will increase the chances of operated deliveries. Why so? Because this is a floating baby. If the head engages, then you're looking at the vaginal delivery. If it doesn't engage, you are looking at operated delivery in terms of lower sections LSCS. So chances of C-sections are very high because of the floating head. In a case where the liquor is in excess, more than 25 centimeters, as I said, it is known as a polyhydrosis. Now, current era buzzword, what is Doppler? Everyone needs to look at the Doppler flows. What is that? Let's talk about placenta and the fetus and circulation. We know that umbilical vein is the one which carries oxygenated and a blood which is in nutrition, which is with full of nutrition to the baby. Umbilical vein carries this blood to the liver. It bypasses the liver, goes to ductus venosus, and from ductus venosus it enters inferior vena cava, and that gets into the right atrium. We all know this. Umbilical artery is the one which carries hypercarbic or the high CO2 blood with lot of waste products from the fetus, and that goes to the placenta. So you're targeting umbilical vein and umbilical artery Doppler assessments. Now you look at the umbilical artery because that's a pulsatile. So umbilical artery is the one which takes dirty blood to the placenta. If there is anything wrong with the placental circulation, say there is increased resistance, this blood will face some problem in getting to the getting to the placenta, isn't it? Because there is resistance there. This umbilical artery blood will not go towards the placenta because resistance is high. That is one. Normally, when there is in all vessels, there is some flow of the blood which can be measured. That's continuous flow is there in any vessel. Umbilical artery also has got some blood. And this blood, when there is a ventricular fetal ventricular contraction by ventricle, this output of the both ventricles, which is coming to the umbilical artery. So when the fetal ventricle of the fetal heart contracts, there is wave happening in the umbilical artery, which is systolic flow. And one which is baseline is diastolic flow. So with each ventricular contraction, the systolic flow occurs and it goes to rest, and that is diastolic flow. We'll take in the figure little later. So for a healthy umbilical flow, if the placenta is fine, you get a good systolic rise, good uprise, and then and then there is diastolic flow. For all vessels, you are looking at different waves. We'll take it one by one. But what I want to convey that we need to remember that umbilical artery flow is very important for the placental to pick up the placental dysfunction. The moment umbilical artery flow is in trouble, is compromised, or you see the umbilical artery flow is abnormal, that suggests that placental dysfunction is happening. And because of the dysfunction, there is resistance which has increased. Because of the resistance, the fetal umbilical arterial flow is abnormal. We'll take it one over. So when it comes to Doppler, during the first trimester, you are looking at uterine artery as we discuss. High uterine artery or abnormal uterine artery Dopplers are associated with some abnormal outcomes. You also look at some indirect marker of aneuploidies, which are those ductus venosus flows and tricuspid valve flows. Second trimester, you are looking at again uterine artery, umbilical artery, MCA, and ductus venosus flows. And third trimester, you're looking at only three, which is umbilical artery, MCA, and ductus. Uterine artery is a predictor of PIH and IUGR. So that is to be assessed in first and second trimester. Once the baby is growing, your uterine artery flow is of not great importance. You are looking at MCA, ductus venosus, and umbilical artery flows. So what is tricuspid valve flows? It is always biphasic. You are seeing E wave, and when this atrial systole, there's another which is emerging, there is A wave. An abnormal tricuspid valve is associated with some cardiac defects and aneuploidy. As I told you that this is associated with knuckle translucency. And both abnormal, there is very high chances of cardiac problems or aneuploidy. Uterine artery flow, we against that systole and diastoles. You can see here, this is normal diastolic flow and this is decreased diastolic flow. Systole is normal, but diastolic flow is quite low. And this is predictor of severe PIH or preeclampsia, and this both ultimately in the long run will lead to IUGR. As we discussed, this happens in first and second trimester. So if appropriate intervention is done in first and second trimester, mother can be treated right in time so that baby can grow properly and mother will not end up with this problem, which is PIH or preeclampsia. Now coming to umbilical artery, we discussed a little earlier. This is systole, this is diastole. This is normal flow in the umbilical vessel. Let's think that there is increased fetal vascular resistance. When there is resistance here, the blood umbilical artery flow will not go there. There is actually no flow. The blood will flow only when the fetal ventricle squeezes or contracts. And that gives the picture of absent diastolic flow. So systole is there, diastole is not there. And this abnormal waveform suggests at least 60% placenta is obliterated. Abnormal waveform. Now, when resistance is very high, the blood goes and comes back immediately. There is no way that it can go forward. There is no forward flow. It goes and comes back. So that is sort of a reverse flow. And when this is reverse flow, that means 70% or more placenta operation, and that means placenta is very badly affected. There is no way by which a fetus can get oxygenated blood or the nutrition from the placenta, and this is suggestive of this is going to end up with very bad fetal hypoxia and acidosis, an acid related problem in form of myocardial contractility and cerebral circulation problems. All this will ultimately end with very bad long-term outcomes. So absent or reverse diastolic flow, these are two things which need to be treated on the Warford basis. Maybe this is a time where at least absent flow, reverse flow will not give any time. The moment you pick up the absent flows or reduced diastolic flow, you at least get fetus ready by giving antisteroids to the mother, so that anytime further compromise of fetus, baby can be delivered, and all benefit that we know of corticosteroid can be offered to the baby. Here you can see that perinatal mortality with reverse flow is 20 to 24%. 1/4 of the pregnancy will be affected, will end up with a long outcome if there is a reverse umbilical artery and diastolic flow. With absent, the scene is not good. 11 to 13% pregnancies get perinatal mortalities. The moment there is increased resistance the fetal medicine specialist, obstetrician, and neonatologist will be on their toes. These are pregnancies which will require more frequent monitoring. Maybe every second day, mother need to be called, or maybe every second week, depending on the overall situation. Mother need to be called for the follow-up, and based on sequential follow-ups or the sequential deterioration in the umbilical artery waveforms, one can decide which is the right time for the baby to come out. We read so many times brain sparing effect. What is that? The moment there is a compromise of the fetal circulation or the fetal placenta circulation, there is a fetal hypoxia and acidosis. Nature will try to keep brain circulation to maximum, and compromise will be oxygenation or the circulation of other organs. So the middle cerebral vessels or the cerebral vessels gets dilated. Blood will go towards that side. Most of the blood will go there. And that's why the vessels in the middle cerebral artery will have more flow. So dilatation of the vessels leading to increased diastolic flow. And that is known as either redistribution or increased MCA flows. And that is suggestive that brain sparing effect is there, baby is getting compromised, fetus is in trouble, better deliver. Because beyond this, it is going to affect brain also. What about health of placenta? Normally, cerebral resistance always is higher than placenta resistance. That is much nature in a normal fetus. So PI of this percentage index of middle cerebral artery is always more than umbilical artery at any period of gestation. So cerebral to placental ratio, cerebral is high and placenta is low. So it has to be more than 1, which is normal. With placental resistance, the placental resistance increases. So the CP ratio gets abnormal. Anything less than 1 is suggestive of high placental resistance, and that is to be again taken seriously. That tells us that now baby is not going to get properly oxygenated blood or enough nutrition from the placental size. Next is ductus venous Doppler. What is ductus venosus? As I said, that's connection with which the umbilical vein blood bypasses liver, gets into ductus venosus, and goes to the infravena cava. When the resistance is very high, the ductus venosus flow also becomes abnormal. Now, if there is a reverse flow in the ductus venosus, that means there is enough problem with the heart, because that's the blood which is going to the heart. When there is the blood is not going towards because of the myocardial dysfunction or any other cardiac problem, that time the ductus venosus flow will become abnormal. Abnormal ductus venosus again is suggestive of need for early delivery. It is also associated with cardiac anomalies and chromosome anomalies, and that is what you can see. The ductus venosus is getting reverse. That's abnormal. Something need to be done. So the $1,000,000 question is, as we discussed with at times the parent, at times obstetrician calling us when to deliver. For example, 26 weeker, no liker, and reverse flow. Shall I keep this baby inside because I don't know whether 26 will survive here or not? If I bring out the baby, baby may not survive. If I keep, baby may continue, and little later 28 weeks I can deliver, or at 20 or we will end up with IUD. So this is the dilemma that obstetrician will have. But in all, when there is a, as I said, early uterine abnormality, uterine artery problem, it's suggestive of placental diseases. Once the placenta is getting affected, uterine diseases, uterine artery abnormal is suggestive of increased placental impedance. And that is suggestive of PIH, as we discussed, PIH and IUG and all those things. Coming to the umbilical artery, when there is hypoxia which is compensated, you get umbilical artery abnormalities. Placenta is there, but not fully functioning. Fetal circulation is compromised. there is increased dilatation, increased diastolic flow. Baby is managing by adjusting the circulation. At that time, you find abnormal middle cerebral arteries, artery Dopplers, brain sparing effect, or increased diastolic flow in the middle cerebral arteries. After that, once there is a decompensated hypoxia, because beyond certain limits, the placenta or the fetus circulation will not able to compromise. As such, there are very few hormones which can control the fetal circulations. Most of the hormones are coming from the placenta. Placenta is affected, so fetal circulation cannot be readjusted depending on the placental hypoxia or placental oxygenation. So what you look at the isthmus, you look at the ductus venosus. If this is abnormal, it's suggestive of myocardial dysfunction, cardiac ischemia, and that's decompensated hypoxia. So you can see here, placenta is abnormal, umbilical vessels, placenta circulation is in problem, fetal circulation, middle cerebral artery. Still, you want to keep baby inside, you look at the Doppler flow of the ductus and aortic isthmus. If they are normal, you may continue their pregnancy. If they are abnormal, you are looking at a decompensated baby in uterus that is to be delivered. In delivery room, next test would be your CTGs, and CTG is abnormal. That's end of the whole thing. Baby need to come out by any means. This is international sonologists or obstetricians guideline Barcelona classification. I'll say these are different gestation age from 24 weeks to 38 weeks. This is what they say, that abnormal flows monitor every 2 to 3 days unless delivery is indicated. When delivery is indicated, based on the ductus venosus flows. Absent flows, ductus is all right, you continue. But when there is reverse flow, even you don't look at the ductus venosus flow, you are looking at STV, and that's the one. Just single time variability, and if that is abnormal, then you are supposed to deliver this baby. Variability in the fetal heart rate, and if it is abnormal, that means baby is compromised. We are not supposed to decide all these things. From neonatal point of view, what I would suggest that the moment there is abnormal Doppler flows in form of absent or reverse flow, I would tell my obstetrician to give steroids and inform that this is the one we should come out with max self if you are delivering before 34 weeks. These two are must. After that, because you are buying time so that fetus gets ready and we can have a better neonatal outcome. Let obstetrician sit on the baby, but beyond certain limits, don't allow to continue the pregnancy, because it is the fetal outcome, which is neonatal outcome, that also matters most. At times, they're afraid of our capacity or of our ability to save those small and sick babies. A compromised fetus is no good than a small premature baby or the extreme low birth or the VLBW babies. A healthy preterm babies, maybe 24, 26, is much better than a compromised 28 weeker. And that is mainly for the long-term neurological or the physical outcome. Anyway, so that is about the guidelines. Sorry. So these are the different things that were discussed. That was the usefulness of the various Dopplers, umbilical artery Dopplers, uterine Dopplers. There is no need to repeat those things. Sorry for the trouble. Is not moving. Now coming to the $1,000,000 question. What is FGR, IUGR, and SFD? SFD stands small for death, FGR stands fetal growth restriction. IUGR stands intrauterine growth restrictions. Basically, FGR, SFD, IUGR. These three are related to the growth of the baby in uterus or the growth of the fetus in uterus. SFD is the one which has started with the lower potential in uterus and has grown on the same potential. So small for date, they grow continuously but at the lower centile, and that is the SFD. FGR and IUGR. FGR is the one which has not grown up to their potential. So a baby who was growing well and suddenly because of any fetal or placental or metal reason is now not growing well, that is your fetal growth restriction. And IUGR is the one which is again has not developed to potential, but that shows the signs of malnutrition. So that is after delivery, you realize that this baby is saying no fat, wise man's look, visible ribs. All this will suggest you of or the shrunken abdomen and loose folds of the skin. These are all suggestive of IUGR babies. So when you are talking about in utero diagnosis, you are looking at SFD or fetal growth restrictions. What is the difference between early and late FGR? Early FGR means any growth restriction diagnosed before 32 weeks is early FGR. And anything after 32 weeks is late FGR. We'll not get into this detail of how to pick these FGRs. What we need to learn is that early FGR, they are chronically compromised. So before 32 weeks, the baby is getting good resistance. So their survival is good, but long-term outcome is not good. Late FGR, they are growing all right, and suddenly some insult has taken place. So maybe at delivery, they can create trouble. But in all, because of a short time insult, the long-term prognosis is very good with left FGRs. This is typical normal growth. Baby is growing in 50th centile. This is your SGA. Their baby started with the lower centile here and is growing on the same centile all through the pregnancy. This is typical your SFD or short for small for gestational age or small for date. This is your early FGR. You can see that, sorry, this is the wrongly labeled. This you can see that baby's growth is affected, start affecting before 32 weeks. And this is again seen, baby was this relative bias, so because baby was growing with a good potential, still it has not gone below third centile. Growth is definitely affected, but it's not falling into typical FGR definition. This may overlap. All SJs are not IUGRs, all IUGRs are not SJs. As I said that at times you find a very healthy baby, but small, bonsai baby. So that is not IUGR, that is your SFD or SGA. As I said, IUGR is the one where you find signs of malnutrition. So how they do look like? This is your 2.4 kg, 39 weeker. 39 weeker, you expect weight more than 2.6, 2.7. Here we are 2.4. So definitely this is small for gestation age or small for date SFD. But it is constituted small because genetically this baby is small. This is your typical full-term pregnancy with very low birth weight, 1.7 kg. And that is your IUGR, or again, it falls as SJ because it is growing below the centile. But this is the one which has all signs of malnutrition, and that's why I call it IUGR. And the same thing, even at 39 weeks, 2.8 kg baby, but signs of malnutrition, loss of fat, loss of the plate, costochondrosis disease, and the shallow abdomen. These are all in favor of IUGR babies. So which are the sign of malnutrition? Large jade, we all know large ventral absent buccal fat, small scaphoid abdomens. These are different things, large fingernails, dry skin. These are all suggestive. If these signs are there in a given case of SGA, it is known as IUGR. These are the photos that we based on which we pick up the IUGRs. What is the difference? IUGR babies, parental outcome is worse in compared to SGA because these are similar to normal fetus. As I said that they are growing at lower centile, but nutritionally they are otherwise fine, and that is why the long-term out parental is good. There is true growth delay here. There is a continuous growth delay. So actually the growth delay is not there with SGA baby. IUGR is the one where the growth delay is there. There is redistribution of the Doppler ultrasound, and SGA is normal. Abnormal adaptation is always there in the IUGR, in the SGA is not there. And eclampsia, chances of as such, the IUGRs are the one where the PIH or any maternal factor or maybe eclampsia is run, which end up with IUGR babies. SGA baby, chances of eclampsia are very less. So which are the interventions? Which are the ways by which you can treat all these problems? Aspirin. How does aspirin helps in these pregnancies? Aspirin is the one which improves the fetal-placenta circulation. How does this happen? It balances the act of prostacyclin and the thromboxane. Prostacyclin is responsible for the vasodilation and inhibitor of the platelet aggregation, whereas the thromboxane A2 is a potential vasoconstrictor and it promotes platelet aggregation. So, at lower doses, aspirin irreversibly acylates COX-1 enzyme, resulting in decreased placental dysfunction, decreased placental synthesis. So, placental clots will not happen, or sorry, platelet clot will not happen in the vessels. By preventing these clots into the vessels, there's a better perfusion or better placenta circulation. So the placenta is well perfused, better oxygenation, more nutrition for the baby, better environment for the baby. So all mother with one or more high risk factor or more than one of moderate risk factor, they need to be on low dose aspirin, 81 milligram per kg or per day between 12 weeks up to 20 weeks of the pregnancy. WHO recommends is 75 milligram, but the moment you find any problem in form of risk factor, one or more than one in moderate risk factor, risk factors have been decided by obstetricians. There's different separate charts for this, but the moment, and these are the one which are with the abnormal flows or abnormal LICA or the small baby, growth delays, problem with the previous pregnancies, fetal losses, all these are risk factors. And based on this risk factor, in current pregnancy, mother is to be started on aspirin either in the first trimester or second trimester. Earlier is the better. We know about Maxsulf. This is the one which is responsible for better neurological outcome. So hence, the moment you find that chances of preterm delivery is very high, particularly impending preterm delivery before 34 weeks of 32 to 34 weeks of gestation, mother should be on Maxsulf. It is to be given intravenously. 4 gram is the loading dose, and then 1 gram per cover for next 6 to 8 hours till the baby is delivered. This is what is there. In short, in conclusion, I'll say that it is important to know the in utero events. Most important part for me also, it helps in counseling, because the moment fetus is in trouble, mainly around 12, around second trimester, at the 2 or 3, there are 2 or 3 landmarks where the obstetrician will involve neonatologists, or the 2 or 3 time period during pregnancy. First is at the major scan or the date scan, we call it, where some anomalies are found in form of some corpus callosum anomalies, some arachnoid cyst kind of thing, something wrong with the kidney, something wrong with the placenta, or something wrong with the heart. These are the malformations. So what would be the outcome of this malformation? That is to be counseled antenatally, and that happens generally at time of the date scan, which is at 18 weeks. And then you are looking at second trimester end or third trimester this is a time where the Dopplers are happening, LICA is to be look into, and the fetal growth is looked into. So these 3 are very important to pick up whether baby is compromised or not, fetal hypoxia and SOD is happening or not. And this is definitely associated with the long-term outcome. Each day in utero increases prognosis by 1%. So you need to be judiciously balancing the risk and the benefit of keeping this baby inside. And how would you do that? Based on the information that has been given to you. I am not a sonologist. Neonatologists are not sonologists. You are not seeing the mother also. You read the reports, and you may ask for more information to the patient or from the obstetrician. And based on all this information, putting it together, you may help in deciding which is the best time for the baby to come out. And while you are deciding this, do not forget to offer steroid and Maxelf to the mother. Thank you very much. Hello.
Yes, sir. Lakshmi? Hello.
Yes, sir. Yes, sir. I'm here.
Can you see any questions on the chat
Yes.
box? Please proceed.
We have requested everyone to post their queries in the chat box. So far, we haven't received any. But sir, that is such an elaborative session on both